Good morning or good afternoon, everyone. My name is Genevieve Frazier with Rogers Behavioral Health. Joining me today are Dr. Nathan Butzen and Dr. Patrick Michaels, who will be discussing several evidence-based treatments for PTSD and sharing their clinical experience. Before we get started with the content today, here's a quick overview of today's program. The webinar is scheduled for a full 90 minutes. To receive credit, you must be logged into the webinar for the entirety of the program. Your attendance is tracked via the Zoom login and logout records. A PDF of the PowerPoint slides, as well as a full list of references, will be available on your personal dashboard at ce-go.com. And a recording of our webinar will be published to our Rogers YouTube channel and the website within a day or two for you to rewatch. Our speakers will give a 70 to 75 minute presentation. Following the presentation, I will facilitate a question and answer session. During the presentation, if you do have any questions, please use the Q&A button at the bottom of your screen. I will review the questions submitted and note that I might combine similar questions if they are related. And finally, we have enabled closed captioning for this program, which you may choose to turn on from the taskbar at the bottom of the Zoom window. Now I'll turn it over to our presenters.
Thanks, Genevieve. My name is Dr. Michaels, and Dr. Butzen and I are proud to present today's presentation to you. This is our disclosure slide, just indicating that we have no financial relationship or any conflicts of interest for our presentation today. As we turn to the next slide, we just want to cover the learning objectives that we'll be covering today. I know this was included in the promotional materials, but just to recap, today we'd like to focus on at least helping you understand at least two components of the 2024 APA guidelines for best practices when working with adults who have complex trauma histories. Secondly, we'd like to describe at least one similarity and one difference between written exposure therapy and other established evidence-based treatments. And then finally, we'd like to take an opportunity to talk about how incorporating behavioral activation and wellness strategies can really assist in resilience, adaptability, and community belonging for folks with PTSD. As we will be further covering in this webinar, we'd also like to discuss diagnosis and guiding principles in working with adults with trauma. And we have some select evidence-based trauma treatments we will review today, and then we will again focus on recovery from trauma and the promotion of resilience factors into designing full lives for folks with trauma. So my name is Dr. Michaels. I am a regional clinical director here at Rogers Behavioral Health. I'm a clinical psychologist by training. I also have a background of working with veterans and worked at the VA for over 10 years. During college, I started as a phlebotomist. From there, I also finished my internship and postdoc and was employed as a clinical psychologist as well as a program manager, specializing in working with people with severe mental health conditions, including schizophrenia and chronic PTSD. I trained in cognitive processing therapy and social skills training and motivational interviewing. And I bring all of those experiences to helping folks make the best of their lives with the challenges they have, finding community inclusion, finding communities that help them express themselves and find that love and belonging that each and every one of us desire. In terms of my pronouns, he, him, and his. I'm white and able-bodied. I'm also a father of two children that are 14 and 10 that keep me very busy and keep me watching lots of soccer. And I am a husband and I've been with my wife for almost 20 years. And with that, I'll turn it over to Dr. Butzen.
All right, thank you, Dr. Michaels. I am Dr. Nathan Butzen. I am the Director of Outpatient Services at our Rogers Clinic in Atlanta. I've been with Rogers for the past 2.5 years. I'm a clinical psychologist. I'm also a veteran. I served as a 73 Bravo clinical psychologist with the U.S. Army Reserves with the 5th Medical Brigade in Birmingham, Alabama. So I've experienced working with active duty service members, as well as activated National Guard and Reserve soldiers. I trained in cognitive processing therapy and prolonged exposure therapy with the Center for Deployment Psychology. And I was part of the team that implemented written exposure therapy at our clinic in Atlanta. My pronouns are he, him, his. I am white and able-bodied. I'm a father and a husband. I'm also once divorced and the child of divorced parents. One other thing I want to say is Happy Veterans Day to everyone. We really appreciate you coming and joining us for this webinar. We just want to honor veterans and family members of individuals that are on this call that have served in the United States military. So we wanted to put that shout out as well. All right, so we're going to start today's webinar with talking about diagnosis and guiding principles in working with trauma. So we want to talk first about the DSM-5 diagnostic criteria for PTSD. So the criteria have changed slightly since DSM-4, and we want to point that out, but criterion A has remained the same, and that's exposure to trauma. And that trauma could be actual or threatened death, serious injury, or sexual violence. You can also be diagnosed with PTSD if you've witnessed those traumas, learned about those traumas happening to a close friend or family member, or had indirect exposure, like the type of exposure that first responders experience to trauma as part of your workplace. Criterion B is intrusion or re-experiencing symptoms. You need at least one of those. You need at least one avoidance symptom, which is criterion C. We're going to skip criterion D for a second and come back to it. Criterion E is increased arousal or reactivity. 2 symptoms are required. As you know, symptoms have to last more than 1 month. If it's less than a month, you diagnose acute stress disorder. The symptoms have to create significant distress or functional impairment, and they can't be due to medication, substance use, or other illness. As we go back to the changes that have happened for DSM-5, persistent negative alterations in cognition and mood was added to the diagnostic criteria, and it requires 2 symptoms. So you can, we're going to talk about the ICD-11 criteria in a second, but there's been a discussion about complex trauma that's been going on in the field for quite some time. And the DSM-5 and ICD-11 took different paths in addressing complex trauma. DSM-5 actually raised the bar somewhat on diagnosing PTSD by adding this symptom cluster, because while many people do experience a lot of these symptoms with PTSD, not everyone who met criteria under DSM-4 would meet criteria for these additional symptoms. I've also highlighted in blue a few symptoms that fall under the complex PTSD definition in ICD-11, and those would include negative beliefs about self, persistent negative emotional state, and feeling detached or estranged from others. Another set of criteria that have been discussed in reference to complex PTSD are dissociative symptoms. And for DSM-5, they added that as a diagnostic specifier. So if someone's experiencing depersonalization or derealization, or both, they can get the diagnostic specifier of dissociative. Additionally, we still have the delayed onset specifier, which is for when someone might meet some criteria of PTSD initially after the trauma, but full criteria are not met for at least 6 months. And they may not meet any criteria also until a delayed onset as well. So let's move over to the next slide where we're talking about complex trauma. So we want to recognize that prevalence rates for PTSD may differ by how you define PTSD, as well as by the study sample. And there were different samples used for both ICD-11 and DSM-5. But as we measure the rates, we've put the references there for the studies that we were using for these samples. You'll notice that the ICD-11 criteria says there's a 7.2% lifetime prevalence of PTSD based on those definitions. And the DSM-5 criteria identifies a 6% lifetime prevalence of PTSD. So what's the difference in these 2 definitions here? So in ICD-11, they kept their definition of PTSD from ICD-10, and they also added a new category called complex PTSD. And this is for individuals who meet the criteria for PTSD, but also have disturbances in self-organization, DSO. And these are significant difficulties with affect regulation, negative self-concept, and disturbances in interpersonal relationships. In the DSM-5, as we noted before, some of these criteria are integrated into their diagnosis for PTSD. So with the ICD-11 criteria, they actually found that more people meet criteria for complex PTSD than they do just for the prior definition PTSD. It's about 52% to 48%. So when we're talking about trauma and PTSD, we think it's important to recognize that more people may be struggling with complex forms of PTSD than simple PTSD. So moving on to this next section about adverse childhood experiences. The question is, do these adverse childhood experiences matter? When complex trauma was originally proposed, many researchers and clinicians were noticing that individuals that had early childhood trauma, such as childhood sexual abuse, were experiencing many more long-term emotional and physical consequences of that trauma. And so they developed a screening tool. It's been around a long time. It's in the public domain if you'd like to obtain it. It's called the Adverse Childhood Experiences Scale. And they identified 10 types of childhood trauma that may lead to negative outcomes later in life. And those are physical, emotional, and sexual abuse, physical and emotional neglect, and 5 different forms of household dysfunction. So that would be somebody in your home having serious mental illness, witnessing your mother treated violently, which they found had a huge impact on boys, especially committing violence later in life, having a high conflict divorce within your home, having a first-degree relative, typically a caregiver that is incarcerated, and having substance use problems present in the home. So in general, 3 to 4 trauma categories was found to be the tipping point to have more severe long-term impact on someone's physical and mental health. However, importantly, where this doesn't apply to the client sitting in front of you is that it doesn't take into account individual protective factors, resiliency factors. So the rule for the group may not apply to the individual that's sitting in your office. However, when we're talking about identifying traumas from a developmental perspective and also trying to determine what an index trauma may be for someone's treatment, I think it's really important to gather this information. We also know that when you screen for a variety of mental and physical health issues, you're much more likely to identify those issues versus if you're not screening for them. We know that some individuals are much more likely to report something on a screening tool than they are to tell you verbally that they've had one of these traumas occur. Additionally, a recent study in 2025 found that in veterans, notwithstanding 3 or 4 traumas, if they had either childhood emotional neglect or sexual abuse, these 2 traumas in particular, either of these traumas were tied to more negative outcomes for them later in life. So we do think it may be really important to screen for ACEs, especially in certain groups that may have differences from other groups, in this case, veterans. So knowing that for the veterans that you're working with may be really important to the treatment long-term. Okay, so Dr. Michaels, I'm going to turn it back over to you.
Thanks, Dr. Butzen. We believe that talking about ACEs and thinking about the things that happen early in life, as well as the things that happen over the entire lifespan, are worth considering. Some research suggests that about 80% of people with PTSD have at least one co-occurring mental health condition. And so it is worth considering people from a holistic perspective, because we know that PTSD affects people's whole body. It affects the people around them, and it affects how they behave in their communities. And we want to consider a number of factors so that we can help address comprehensively what is sitting in front of us and help that person adjust and find a way forward through our assessment techniques and the ways that we can help folks be treated. If you look on the left-hand side, depending on the kind of trauma that somebody has as an index trauma, if somebody is in a car accident or if somebody is hurt in service through an explosion, there may be some experiences physically that they end up having as chronic conditions, or maybe they've been exposed to burn pits or other things in service. And it is worth considering and evaluating how chronic pain, things like IBS, and even neurological conditions like traumatic brain injury are affecting the person in front of you. It may affect how they process information, how they remember things, and certainly it might affect their sleep. We know that nightmares are very common in folks with PTSD, or even folks, depending on the kinds of meds that they're taking over time, they may end up having an acquired condition of obstructive sleep apnea as well. So it's really worth considering the co-occurring physical health conditions in this clinical picture. Now, in terms of the middle category, there are lots of mental health conditions that might also co-occur with people with trauma. With the background that I have in working with people with severe mental illnesses, people with schizophrenia and psychosis, who may be at higher rates for homelessness or other may not have a place to live. They may be subjected to violence or be victimized by other folks, and so they may have an acquired interpersonal trauma from those environments. If folks are in in service or in other spaces, there are a number of other conditions that may also co-occur as are listed here. So it's really worth trying to understand how these conditions intersect so that we can think about a transdiagnostic way to address these concerns. As you take a look at the right-hand side, we often find that there are a lot of things that are worth considering in terms of maladaptive coping strategies or behaviors that may be present. Some of these may be ways that we have seen folks try and cope with trauma. I've certainly worked with folks who have used self-harm behaviors as a way to manage emotionality. Certainly substance use is no secret as a way that folks have frequently have used cannabis or alcohol as a way to manage their emotional dysregulation that is very difficult to navigate through. So it's really worth considering what kinds of things folks are presenting with in your office, because in addition to working with a trauma treatment, we may need to think about some of the coping skills or other interpersonal effectiveness strategies that may help them connect with other people and be understood both in their home lives and work environments, education, just in different spaces to help them be successful. As we take a look at the next slide, folks are probably very familiar with some of the assessment tools that are listed towards the top of this slide. We really want to shout out the National PTSD Center that the VA has. It is a wonderful repository of not only articles, systematic reviews. It discusses PE, CPT, lots of things. There's videos, there's resources for family, there's all kinds of things to help understand trauma. But for the clinicians, we just want to emphasize or even remind folks about the importance of really being able to establish that criterion A. And the life events checklist is one of those particular tools that can really help us systematically take a look at the things that folks may have been directly exposed to or may have vicarious trauma across a number of different conditions. The Clinician's Assisted PTSD Scale, or the CAPS, is also a really important tool for understanding the context. Certainly folks, as Dr. Butzen was talking about earlier, may have exposed to a number of traumas early on in childhood or throughout their life, but trying to determine which index trauma is the most important to address in our treatment is of critical value to us. And a lot of times it's difficult for folks to transparently come through with what that index trauma is initially. And so it's really important for us to be able to accomplish that. In terms of tracking treatment, we believe in measurement-based care and treatments like cognitive processing therapy and PE and are using assessment tools session after session to try and track the cognitive, emotional, and behavioral progress to try and help clinicians know where we still have some work to do with folks to help them make more progress. So the PCL5 is one of those really important tools to administer on a regular basis to understand that. As you look down, I think a lot of folks are familiar with the Patient Health Questionnaire 9 or even the Beck inventories for depression. Two tools that we'll talk about a little further on in our presentation are the QIDS and the BADS. And the QIDS is a depression inventory that we often use in our institution as a way to understand depressive symptoms. And the BADS is a tool to understand behavioral activation as a way to not only as we're trying to work on treating behaviors that are not effective for navigating through trauma, we're also looking at trying to focus on wellness strategies and building out new patterns of behavior that can focus on people living a meaningful life that has connection and enjoyment in it. And so we are also tracking some of those new positive behaviors and decreased avoidance over time. So we're looking at those behaviors as well. On the previous slide, we had talked a little bit about substance use disorders. We want to just make a big plug for the ASAM and the criteria there. Certainly, if folks have physiological dependence to specific substances, it can be very important to in that determination for what the level of care might be, whether it could be residential or whether outpatient makes the most sense. Certainly, if folks are who are struggling with alcohol use disorders, are having blackouts or physiological dependence, it may be more difficult for them to make progress in a trauma treatment if the substance use disorder is really the primary presenting problem at this time. Lastly, we're very interested in subjective well-being and the quality of life inventories, which we'll also talk about later. These really buttress up the ideas of the behavioral activation scale that I've mentioned earlier. But we're looking at really trying to improve people's lives across a number of domains. And that subjective understanding of well-being can be very important for us in terms of helping people achieve that through the work that we're doing with them. So as we turn to the next slide, this is one of the things that we're really excited to present today. And these are some APA guidelines for a complex trauma history. And one of the things I want to just mention is that these are professional practice guidelines. And those are different from consensus guidelines, such that the professional practice guidelines are a lot of experts coming together to try to put together something to help initially guide us for working with folks with complex trauma. And in the work that Dr. Butzen and I do, we frequently have folks who present with complex trauma or with PTSD, along with another bunch of co-occurring disorders or physical health conditions. So we often are working with folks who have quite a number of functional impairments and are struggling in quite a lot of areas. So one of the reasons that taking a look at these guidelines is important is it helps us to separate out how we assess and how we can treat people and how we can design our care so that folks connect with us, build rapport, have a therapeutic alliance, and how do we build a space where people feel like they are psychologically safe and can begin to develop trust in our space. And so these guidelines end up helping us understand how to do that. So if you look at the first principle, this is the humanistic principle. And one of the big guiding lights here is to help us devise a way to support dignity and self-compassion and really embracing the recovery-oriented ideal of fostering agency and really empowering the person to start working on this difficult work to address trauma. The second principle addresses integrative. So we are focusing on the whole person, not just on one part of them. We realize that physical and mental health go hand in hand. So we're looking at incorporating evidence-based treatments, but we also want to work in a client-centered way with shared decision-making and really addressing what people are presenting us with. If they're not willing to work on things and we don't have a shared goal, it's going to be a lot more difficult. And to that extent, we really want to make things really patient-centered, client-centered, so that they're getting the treatment that they're looking for. And we can, and then, which leads us into this third principle, which is the appropriate sequencing. So folks are familiar with the ideas inherent in motivational interviewing and the stages of change. We're really trying to embody where folks are at, taking a look at maybe some of their day-to-day functional impairments, and really trying to help give them the sort of enriched environment to help them learn coping skills or present them with, trauma treatment so that we can make some progress, so that we can help them build that self-efficacy, that self-confidence in what they're doing. The fourth principle that's in this guideline is timeline. So the impact of a trauma history over the course of an individual's lifespan. One of the things that's really important here is if traumas, like a military sexual trauma or some other trauma has happened early on in their life, it may have a very different impact on that person than if it occurred later in their life. And we have got to also understand what some of the intergenerational understandings or some of the patterns are, or even if there's a family history of trauma, to help somebody maybe even habilitate and find a new way forward to try to grapple with and find resilience. The next principle here is one of outcomes, and you've heard us already talk about measurement-based care, which is something that we greatly believe in trying to understand what some of our best objective measurements are. But we're also looking at some of the functional improvements that people can have in their life. Can they go back to work? Can they get back into school? Maybe folks have dropped out. Maybe they haven't. Maybe they are alienated from their family. Can we get some of those behaviors, to be adapted to and to be changed? And of course, that would all be client-centered work that we would focus on. The second to last principle is one of relationship. So we're really focused on really building rapport, setting boundaries, but allowing them the space to explore their identity and who they want to be, to build out a life worth living in a recovery-oriented environment. And finally, a lot of folks are seeking an answer as to why these things happened. And one of the things these principles really talk about is interpersonal violence is some of the most difficult to treat, because that is some of the most difficult for folks to understand and grapple with. And there's a lot of blame and responsibility and existential themes that might be explored in that space. And with that, I'll turn it over to Dr. Butzen to walk us through how we take a look at this in our environment.
Excellent. So Dr. Michaels and I wanted to really flesh out these guidelines, these history guidelines for an episode of care for complex trauma. So we initially developed this table for ourselves, and we know it's got a lot of content in here. But what we did was identify various tasks that we might undertake during an episode of care, both during the assessment phase of care and the ongoing treatment phase of care. So this table's here for your reference. I'm not going to read the whole thing, but we'll talk through a little bit of this for a client that has a specific goal. So let's imagine that we have a client with PTSD. And as we're getting to know them and determining in that initial humanistic section, right, understanding their preferred pronouns and names, doing our culture and values assessment, that our client identifies that one of their goals for treatment is to improve the romantic relationship that's been damaged by PTSD. And this is something we see a lot. We know that's part, those interpersonal relationship problems are part of the definition for complex PTSD now. So we have an individual with these relationship challenges, and we're trying to assess them and understand what they're going to need. So as we go through the integrative component of care, we're going to be looking at the whole person, right? Physical health, but we're also going to be including quality of relationships in that assessment, and potentially the need for other specialties, as well as what kind of care they've got in the past. Specifically for their romantic partner, we may want to integrate into this assessment. Have you ever received counseling before? Have you met with a spiritual or faith leader about your relationship? So what's that individual already done to try to address those relationship challenges that they've been having, or have they done anything? And so we're balancing out both that present goal of fixing the relationship with the past focus on trauma and perhaps trauma in the relationship. As we look at sequencing for the client, the question becomes, when would the patient be able to address relationship concerns based on their current symptoms of PTSD? So again, we're going to be looking at readiness for change. When we get into the timeline of the trauma, we really want to understand the onset of their trauma specifically. Has there been trauma in the context of this relationship? Has there been trauma in the context of other relationships? Was there early childhood trauma that was relationship-based? So we're not just looking at what happened, but when it happened and with whom, so that we can really understand the developmental phase of the trauma. Something else that's really important in this assessment phase with this client is current safety risks. For instance, when there's relationship distress, is our client engaging in self-harm? Do they have the ability to regulate their distress when things are not good in the relationship? Additionally, is there other types of safety risks? For instance, is there common couple violence or more severe domestic violence going on? And that may change when we would be able to address some of these concerns. But at this point, we're just trying to go through the assessment to understand what's happening. Under outcomes, of course, we're going to use our outcome measures, but we may need to add some things to that, right? So we may need to look at self-harm. We may need to look at addictive behaviors, the potential for dissociation within the relational context. Additionally, we may want to look at relational well-being, right? I mean, we may pull out some scales for that to identify satisfaction in the relational context. So as we get into the relationship section of the guidelines, this becomes really important when you're dealing with relationships, right? We want to understand how that client makes boundaries. We want to identify that we're building a strong therapeutic alliance at the beginning so that our client can trust us, so that this can be a safe place to explore those relational needs. And starting to look at that parallel process, what the client brings in, what the client might be projecting onto the therapist, how that there might be similarities between the client-therapist relationship and the relationship with the romantic partner. And then we're going to try to explore in the assessment phase their understanding both of what happened with the trauma and historically, but also in the present, what's going on, where's the blame and responsibility in the relationship, how do they make sense out of the relational challenges that they're having. So as we move into the treatment phase, we are looking at recovery-oriented care, that's strength-based, that this relationship, may have gone through a lot of hardships. Maybe they've been in the relationship through a very difficult trauma. So we want to honor that and honor that this relationship has also been through a lot and that this individual's overcome a lot. As we get into the integration phase, again, we're taking into account their cultural and spiritual practices, and we're starting to consider, do we consult with that partner? Can we bring in the romantic partner for a consult? Do we need to get a ROI with other therapists that have worked with this couple in the past? And how does this treatment proceed in phases as we sequence it? For instance, if we have a client that has a lot of increased arousal symptoms, so that in the context of the relationship, every time they try to have a difficult conversation with their partner, they're having angry outbursts and lashing out verbally or leaving the room. Maybe we need to work on those symptoms first, those symptoms of PTSD, before we can address things in the relationship. And that obviously in the timeline, we've already talked about understanding the trauma timeline, but we may need to create a relationship map and genogram so we really understand who in the family system was responsible for any type of trauma in the past, who else has been traumatized within the family system, and that we're doing ongoing collaboration around safety planning. So let's move down to this relationship and the why at the end of this treatment phase. If we've created a safe attachment for our client, the hope would be that we're being able to do relational repair in real time with the client, so that if the client gets offended by something we say, we're modeling for them how to communicate about frustrations with one another, right? That clinical relationship is a laboratory for relationships outside of the therapy office as well. And that we're really modeling shared decision-making, bringing in the client and recognizing what's important to the client, not just what we think is important for them. So as we bring them in as a shared decision maker, the hope is that they'll become more empowered to reach their goals. So finally, at the end of this process, in the why, just as an example, this client may be able to recognize that, as an example, in witnessing violence in my parents' marriage, I learned it was only safe to keep my mouth shut in relationships. In order to stay safe, which has led to me not expressing my preferences and desires to my partner and not getting my needs met, and then getting resentful when my partner does not meet my needs. So I would like to go into couples therapy with my partner in order to have a safe place to communicate about what my needs are and ensure that my partner is able to hear what those needs are and provide a response that's validating. So that's a little example of how you might walk through these guidelines, and we hope that you can apply this to your own cases as well. And with that, we're going to move on to our next section here.
Thanks, Dr. Butzen. I hope folks can see that a lot of this is partially about the kinds of work that you do to build your treatment culture, how your staff interact, and really focusing on the kinds of trust and safety that can be built into the spaces where treatment is provided so that folks can really connect. In our second section here, we really want to talk about trauma treatments and focus on a few select evidence-based pathways. And so on this next slide, we want to talk about two guidelines. One is the VA-DoD clinical practice guidelines, which were published in 2023. And then we also want to talk about that in connection with the American Psychological Association's PTSD guidelines, which were published in 2025. And so the strong and weak recommendations here are framed in terms of the VA-DoD guidelines, which are based on research evidence and are based on quality and are based on how many studies have been published. And so the VA-DoD guidelines indicate that cognitive processing therapy, EMDR, and prolonged exposure therapy are strongly recommended based on their review criteria. In terms of the weaker recommendations, written exposure therapy, Eller's cognitive therapy for PTSD, and present-centered therapy have a weaker recommendation based on the studies that had been published as of when the 2023 guidelines were published. One of the things we would like to put a caveat on here in terms of the weak recommendations, and we'll be talking more about written exposure therapy today, is that there was another study that was published later in 2023 that we believe would move the written exposure therapy guidelines into a strong recommendation in the VA-DoD guidelines. So we would like to focus on that with our presentation further today. The other thing that we would like to highlight is what the American Psychological Association guidelines say. You see a little caution sign here next to EMDR. That does not mean that it's not efficacious. That does not mean that it is a treatment that should be removed from that section. One of the things that is discussed in the APA guidelines is that there are some mechanistic considerations for how EMDR works that remain up for research discussion. And so it is really worth taking a look at what those APA guidelines talk about in terms of how EMDR functions, because there are a number of things that are brought up that remain questions that haven't been answered yet. Dr. Butzen, did I miss anything on the EMDR caveat?
No, I think you covered it. I think there's some questions about the mechanism of action that's proposed in EMDR and, why it's effective. So I think there's some questions around that as well, but ultimately it works, right? Even if we're not always sure exactly why it works.
Well, with that, I think we can turn to the compare and contrast of some of these strong recommendations.
Right. Excellent. So we wanted to lay out briefly, and obviously we can't fully explain each one of these evidence-based practices. We want to at least give a brief explanation of them for comparison, since we're going to be talking about a lot of comparisons between written exposure therapy and these other treatments. So I wanted to say what they are, because we recognize not all of you are probably trained in all of these. So we wanted to give at least a little bit of an overview. And to start out, cognitive processing therapy has been found to be effective with or without a written trauma account. So you do not need to write a trauma account in cognitive processing therapy in order for it to be effective. Instead, you're writing an impact statement about why you believe the trauma occurred. So throughout that treatment, you're identifying stuck points, cognitive errors, and then you're implementing cognitive restructuring strategies to address them. So CPT is 12 sessions, 50 to 60 minutes per session is what's proposed. And it's really a top down, right? We're thinking about thinking in a sense. It's cognitively evaluating the impact that the trauma has had on your life. And so you're looking at a lot of cognitions in this sense. And there's, even though you may write a trauma account, that's not the mechanism of action in CPT. So exposure to the trauma does not need to happen in CPT. Now you're going to see in the next three therapeutic modalities that we are going to have exposure to the actual traumatic event. And that's more of a bottom-up processing where we're processing through the traumatic event that occurred. So second, we're going to go to EMDR. In EMDR, the number of sessions varies. They last 60 to 90 minutes each, and there's 8 phases of treatment. So an individual may move faster or slower through those 8 phases of treatment, depending on how the treatment goes. The primary intervention here is thinking or speaking about the traumatic event while bilateral stimulation occurs. So that may be the classic, eye movements based on a finger movement. They also have light bars in EMDR that can provide bilateral stimulation. And you're going to be doing that, thinking or speaking about the traumatic event with bilateral stimulation occurring simultaneously until your reported distress decreases from wherever it starts down to a 0 or a 1. There's a second component to those EMDR sessions where you're strengthening a chosen positive belief or cognition to counter a negative trauma belief at the end of every session. Additionally, in EMDR, they do teach relaxation techniques prior to getting into the exposure of thinking or speaking about the traumatic event. So we know that thinking about trauma may be a form of exposure. That's unique to EMDR. The other therapies require you to either, share your story verbally or write about it, or in cognitive processing therapy, perhaps you are thinking about it, but in a more removed way. But specifically, the instruction to think about the trauma would be unique to EMDR. And then as we move down to prolonged exposure therapy, it's typically 10 to 15 sessions of 90 minutes each. There's been some research on whether or not 60-minute sessions could be effective, which is promising because it would align more with an insurance payer expectation. It's hard to get insurance to pay for 90-minute sessions, but ideally in the protocol, you would do 90-minute sessions. And the primary intervention here is an in vivo exposure hierarchy to reduce avoidance to trauma-related reminders. And then an imaginal exposure, which is the verbal retelling of your trauma in the present tense. Like EMDR, in PE, we teach relaxation breathing before we go into doing the exposure work. We record the trauma story in the present tense as if it were happening right now, which really is intended to increase engagement around the trauma. And you're going to listen to that audio recording repeatedly, both in the session and outside of the session for homework. And you're measuring your distress throughout different stages in retelling of the story. And the goal is obviously for that distress to come down over repeated retelling of the story. Lastly, we're going to talk about written exposure therapy. Written exposure therapy is 5 sessions, and the research has found that 5 sessions is the ideal length of time for treatment effectiveness. And during each session, you're going to have 30 minutes of uninterrupted writing. So the bulk of these 45 to 60-minute sessions are the actual writing intervention. So the imaginal exposure here is a written narrative about the trauma in the past tense, completed 5 times with scripted instructions, both before and after the writing. So some distinctive components here are writing about the trauma. There's also an instruction to think about the trauma in between sessions to not avoid reminders, thoughts, feelings about the trauma. There's not really a way to measure that in written exposure therapy, but that is one of the instructions. Importantly, in written exposure, aspects of the trauma are not discussed verbally. So the only discussion with the therapist is about the process and the quality of the writing. You're not actually going to talk about your trauma narrative with your therapist. So that's very different and distinct from the other protocols here. Finally, all of these therapeutic interventions want you to monitor symptoms, right? They want you to use the PCL5 or a similar measure to look at PTSD symptom severity before and after treatment and during treatment. So you're going to be utilizing those measures to see if you're getting improvement in trauma symptoms. So we want to dive a little bit more into written exposure therapy. So let me move to that slide. So there was a systematic review of written exposure therapy studies that was done in 2024, and that's what we're citing here. And the good news is the findings were that the written exposure therapy is both efficacious and effective for reducing PTSD symptoms. So multiple studies found that written exposure was beneficial when delivered remotely with a video conference platform, when delivered in a group format with a small group of participants. 2 studies even looked at an adolescent population and found beneficial outcomes there. It hasn't been validated in an adolescent population, but there's some promising work being done there. And so I think one of the main questions here might be, why are we looking at another evidence-based practice? Why are we looking at other treatments when we have cognitive processing therapy and prolonged exposure therapy? Well, this study points out that a third of people receiving treatment with prolonged exposure therapy and CPT drop out prematurely. So if you have 100 people, only 67 actually make it through the treatment protocol. Of those 67 people, a third of them still meet criteria for PTSD post-treatment. So that means that of the 100 people that started out in prolonged exposure or CPT, 45 or better. 45 no longer have PTSD. And some of the dropouts may not have PTSD either. I guess we can't account for all of them, but we know that 45 got better, right? So that would mean that 55% are still unknown or likely have PTSD. So basically, we need other treatments for a variety of reasons. One, if one of our evidence-based practices is not effective, we need to be able to try another one. And two, we need a treatment that people don't drop out of. So I think that's what the next bullet shows. The lower dropouts in written exposure is pretty remarkable. And some people have argued, well, it's a shorter treatment, and that's true. But as we look at dose of treatment, the effective dose is 5 sessions, right? Where it's in that 10 to 15 session range for PE and CPT. So the fact that it's a shorter treatment does help, but they also looked at, do the dropout rates just in 5 sessions of written exposure, PE and CPT, and the dropout rate was still lower in written exposure therapy, just over 5 sessions. Now, the data here show for the therapeutic dose. So for someone to complete PE, complete written exposure, complete CPT, in 2018, they found that it was 6% dropout rate from written exposure versus 40% for PE and CPT. 2022, it was 24% versus 45%. 2023, it was 13% versus 36%. So you can see that it's a much lower dropout rate, which I think alone suggests that this could be a treatment that we should include in our repertoire of evidence-based practices to help those who can't tolerate those longer treatments. Okay, and turn it back to you, Dr. Michaels.
All right. Well, I love case conceptualization, and so I'm happy to talk about the functional assessment of trauma and taking a look at why people experience things the way that they do. At Rogers, we take a cognitive behavioral therapy formulation, but we are heavily focused on the behaviors and are looking at this through more of a behaviorist lens toward experiential change and trying to help people learn things from their environment through how we set up treatment. Now, with that framing, one of the things that we want to do here is to really understand this index trauma. What type of trauma is it? You know, is it a car accident? Is it a interpersonal violence? Is it a trauma of interpersonal violence? What was a person's reaction to it? Were there any injuries? Some of the injuries that might be sustained could be chronic pain. Depending on what happened, it could be that somebody is infertility from sexual abuse or rape. I mean, it can be pretty significant. And the reason I bring that up is because when you think about how information is processed in terms of fear cues, the external, we want to separate out into the external and internal stimuli that could be occurring for this person. And so depending on the situations this person is in, the people, places, or the things in the environment, they may end up functioning as specific fear cues, which in terms of understanding how those cues are processed, they're going to have an impact on a person. Additionally, we would also like to take a look at the things that are coming up from within a person. These could be pain, but it could be hypervigilance, or these could be hyperarousal symptoms. These are things that are going to, cause a person to have, physiological arousal, but there's also going to be intrusive thoughts or images or memories that may come up as a part of this. So we want to try and understand what is happening within a person, but also what some of their feared consequences are. What do they expect to happen? Maybe they're afraid of the distress and really are not sure how to manage their emotionality, because maybe the emotionality comes, it stays high for a long time. Based on how they're thinking, it's really hard for them to end up down regulating. Or maybe they're around people, places, or things that function as regular reminders of the event, and it's really hard for them to stop ruminating or to have those images to stop coming up in their mind. A lot of times we're looking at the function of safety behaviors, and these are ways that people are going to work on keeping themselves safe. They might opt out of environments. So we are looking at patterns of avoidance, whether it's just reminders. It could be that they are not engaging at work. Maybe they don't go out in the community. Maybe they shop in the middle of the night at the grocery store at 2 a.m. so they don't come in contact with anybody. We're looking for some of these avoidance patterns to see what might be some of the learning. They may also have in-situation safety behaviors. They may have, like as Dr. Butzen was talking about earlier, a lot of times people with PTSD they will always bring somebody with them as like a safety person so that they can help regulate their emotionality. Maybe they have weapons nearby in their home just in case something comes about. Maybe they even walk around the house and do a lot of safety checks. So we're looking for the behaviors that they're engaging in that may continue to function as additional fear cues and cues of threat. Lastly, we're taking a look at the beliefs about these safety behaviors and what do they believe is happening. So when they engage in these things, what is the function of that behavior? And so we're really trying to understand from a case conceptualization perspective, what is the sequence of events that ends up happening for this person, kind of maybe as a pattern, or maybe it's context specific. As we take a look at written exposure therapy, in cognitive behavioral therapy with more of a behaviorist bent, we are looking at a concept called inhibitory learning. And some folks may not have heard of this. Certainly before I came to Rogers, I had never heard of this. So this was a new thing I learned about 4 years ago. But when you're looking at imaginal exposure therapy, we are looking at two concepts. One is habituation and one is inhibitory learning. In more plain English, one of the things that we're looking at for habituation is that when people are exposed to fear cues, we often think about their emotionality spiking, but the emotionality will come, peak, and pass. And over a period of time, as long as it's not given any more fuel to stay high, the emotionality will come back to baseline. That happens for all emotions as long as we don't give them fuel. So this will also happen in our exposure writings that we are going to talk about in a few slides a little further. So the more that we write about it, the easier it gets. And so the intensity of the emotionality and the duration of which it lasts should both decrease. From an inhibitory learning perspective, we are trying to look more specifically at these fear structures or fear beliefs. And so part of this is that we realize that there is, if folks have seen the Men in Black, there is no magic eraser for our memory. That is a sort of a permanent record. But sometimes the beliefs that folks have are very large and they're very all-encompassing, and it becomes very limiting. But the belief itself may not be very accurate anymore, or maybe it can be modified so that the world can be sort of unlocked and they can do a lot more things. So one of the things that we're hoping here is to not teach folks to avoid their emotionality. We want to help them understand that they can have more tolerance for their anxiety and feelings, and all feelings are universal and they can be safe. One analogy I often use is we are trying to get people's emotionality to go from like a light switch that goes on and off, and to really offer some more recalibration into having more of a dimmer so that they can not only recognize and understand the gradients, but they can respond to them in kind. So our goals here for inhibitory learning at a deeper level is we want people to learn that there are these thoughts are non-threatening. We want them to learn that they can activate new safety-based cognitions in a wide variety over time. And we really want them to learn that they can tolerate and have more distress tolerance as a part of this new learning. And we're not going to put them in any unsafe situations, but we will ask them to maybe go to the grocery store at an earlier time. Or when they're engaging in their writing, we're going to teach them that thinking about the the writing in this moment, they are safe to do that, and their emotionality is not dangerous. And with that, I'll turn it over to Dr. Butzen.
Great. Thanks, Dr. Michaels. So we're going to talk about a little more detail on written exposure therapy because we want you all to understand what happens in this treatment since it's a less familiar treatment. So I want to draw your attention to what's in the teal box over here on the right-hand side of the slide. The 5 sessions of written exposure therapy that are done with writing are after the initial assessment. So I do want to point out that it may be longer than actual 5 sessions because we're going to complete the life events checklist and or the CAPS-5 before starting written exposure therapy. We really need to get a thorough assessment of the index trauma because it's extremely important. The research shows that we have to identify, one, the right trauma to write about, but also that they're going to write about, our client is going to write about the same trauma each session. They actually did studies where they looked at, well, what if people just write about the trauma that's bothering them for the day, right? Or they write about different traumas. You know, we know individuals with complex trauma may have had multiple incidents of trauma. The important thing is that when we do the writing exercise, they're all focused on the identified index trauma and that we're writing about the same traumatic experience each time. Now, that's not to say we can't do another course of written exposure therapy where we write about a different trauma. If maybe we get through one trauma, we all know that it's pretty common for a client to not tell us their most severe trauma at the beginning of treatment, and somewhere in the middle of treatment, they may say, oh, well, actually, we've been working on this, but it's this. And in that case, we say, let's continue. We're going to finish doing this, written exposure intervention with the trauma we identified, and then we'll move to a new trauma if there's a need there. So optimal symptom improvement is typically obtained in 5 writing sessions. So the research suggests that clinicians, we want to do more. We'd like to do more than 5 writing sessions. We want to increase, but there's not much benefit gained past the initial 5 writing sessions, as long as an individual is following the instructions and doing the writing sessions as assigned. One other interesting finding is that distress when writing is pretty significant, right? Distress is going to go up over the first 2 sessions, and then it's going to decrease significantly by the 3rd writing session. So, and we've seen that a lot when we've been delivering the treatment in our Atlanta clinic. Okay, so in the initial session, you're going to provide psychoeducation about PTSD and rationale for exposure therapy immediately prior to the session. You're going to train your client on how to use the SUD scale and the process of writing. Then there's verbatim scripts within the written exposure therapy for PTSD book, that 2019 book that we cited there. And so the scripts are all in the book, and you're going to read those verbatim and then provide your clients with a printout of the script. And then you don't have to do much after that. You facilitate an uninterrupted 30-minute session for them to write about the trauma. When they complete their writing, we inquire, how was the writing exposure? How did it go? But we don't process the written content with the patient. As I said before, the exposure activity is the trauma writing, and it's complete at that point. So the author specified that we want to spend no more than 10 minutes discussing the process of the writing. And then there's another script about remaining open to thoughts, images, and feelings that may come up about the trauma between sessions to reduce the tendency towards avoidance. After your client leaves, you're going to read the trauma narrative and develop brief feedback for the client about the quality of their trauma writing. And you're going to share that prior to their session 2 writing time. So as we move to session 2, the first thing we want to do is obviously we're evaluating if the client followed the writing instructions and actually wrote about the index trauma that you all agreed upon. If they wrote upon our agreed upon trauma, then you're just going to give some feedback. For instance, you might say, it looks like you did a really good job writing about what happened before and after the trauma, but you didn't put very many details about the trauma itself. Do you think you can write more details about the actual trauma today and get into your thoughts and feelings more of what happened during the trauma? So the other thing we do before they engage in their second writing session is assess whether the client could think about the trauma since the last session without pushing the thoughts away. There's not a structured way to do that, but the authors do want us to ask about that. Like, were you able to think about the trauma? And we're trying to determine if the avoidance of these traumatic memories reduces over time. And we're trying to teach the client, as Dr. Michaels was referring to earlier, that while the trauma may have been a terrible event, the memory is not going to harm us. So that memory is not harmful. It's like looking at a picture of something, and it may be a terrible picture that we don't like looking at, but we're trying to increase our client's tolerance for doing that, right? For exposure to that event. And we know that's going to help them long term to reduce their avoidance around that. So for the second session, we actually asked them to focus on their deepest feelings and thoughts about the trauma. Session 3 is a similar protocol, and the writing session there is going to be focused on the impact of the trauma on a client's view of life, meaning of life, and relationships. So this is somewhat similar to the impact statement that clients write in cognitive processing therapy. So there's a little bit of overlap there as well. In session 4, there's specific instructions that we are to determine if our clients are following instructions for writing. And they remind us if they're not following the instructions, if they're not writing about the actual trauma, treatment may not be successful. So at this point, we would expect to see a decrease in avoidance of places or activities. There's unlike prolonged exposure, which has that in vivo exposure hierarchy that's really looking at avoidance and challenging the clients to avoid less and less and expose themselves more and more to things they've been avoiding related to the trauma. We don't have that in written exposure, but we still would expect to see a decrease in avoidance at this point in treatment. And the writing session is going to be focused on the most upsetting part of the trauma and how the trauma event has changed the client's life. Finally, in the final session of written exposure, we're generally going to give positive feedback about the session 4 narrative, and the writing session will be focused on how the traumatic experience is related to the client's current life and future. So to tie that back to the history guidelines, this is really the why. So the final session of written exposure starts to get into the why, like the client's emerging understanding of the trauma and how it's related to their current life and their future. After this writing session, we do not give feedback about the writing. This is a wrap-up session, and we're simply going to remind the client that they've learned a new skill, a new intervention to cope with traumatic events, and we will ask the client if they feel that treatment was successful. The most common reason for clients to say no, it wasn't successful, or to find that they did not experience a decrease in symptoms, is if they were avoiding the trauma by only writing about peripheral details. So if that's the case, we have a couple choices, right? If there's residual symptoms, we can discuss another evidence-based practice. Do we move to prolonged exposure? Do we move to CPT? There's a variety of reasons we would do either one of those. Or do we try to do written exposure again, but really get focused on the traumatic event? And finally, we have to determine if there's other symptoms that are still persistent that need treatment. Depression, substance use disorder, or potentially emotion dysregulation. You know, perhaps the trauma symptoms have gone down, the client is still unable to regulate their emotions, and they may need like intensively trained DBT team to work with them on emotion dysregulation. So I hope that helps you get a better perspective on written exposure. And we want to talk a little bit about our outcomes at Rogers with written exposure.
Rogers has an excellent data collection process. We collect data at intake and at program discharge and at regular intervals throughout our programming. And so today we want to talk about a sample of about 238 adults that were in our PHP or IOP programs from January 1st until the end of September from this year. You can see our demographics. About 3/4 of folks are Caucasian or white. About 83% are non-Hispanic or Latino. So while that's relatively homogeneous, we do have a good dispersion of age here across these categories, and about a little over nearly 60% of folks are single that are in our sample. We'd like to proudly share our written exposure therapy outcomes data that we have accumulated here. This is based on baseline and post-test data. And so that was what our analysis was limited to. But we want to just talk about the sort of package of care within the next couple of slides about what people are experiencing in our program, because it's not just written exposure therapy. Folks in our partial hospitalization and intensive outpatient programming are receiving other things in addition. However, folks are when they're working on written exposure therapy, that is the unique treatment element that focuses on trauma specifically. And so the average number of days until somebody starts written exposure therapy while they're in our programming is about 8.5 days. Most folks are on average in treatment about 29 days in our PHP or IOP programs. Could be more, it could be less for a variety of reasons. In terms of our outcomes, we have limited the below to people that had at least 3 written exposure therapy sessions. And this data below is representative of at least 80% of the people that received 5 or more sessions are included below. There's a little missing data for the quids and the quality of life and the bads. Just want to acknowledge that. But when we look at the data for folks for the PCL5, for all groups, folks showed significant improvement whether they received 3, 4, 5, or more than 5 sessions of written exposure therapy as a part of our programming. Specifically, our PCL5 scores, you're seeing that 236 people have overall data here, and we have a high effect size of 0.83, which is a significant decline in symptomology. The depressive symptoms are seeing a significant or a moderate decline here in terms of effect size. The quality of life is seeing a moderate improvement. And then, as we talked about earlier with the behavioral activation scale, we're also seeing a moderate improvement in people's activation into healthy patterns of life. As we turn to the next slide, we want to talk a little bit more about level of care considerations. What is a higher level of care? And what are the differences in evidence-based treatments at a higher level of care? And we live and breathe this, but not everybody is maybe familiar with the higher level of care. So one of the reasons that somebody may be in a higher level of care is that we are seeing widespread functional impairments. For convenience, we have separated this out into intrapersonal functioning, so things that are like specific to the individual, interpersonal functioning, and then some community participation issues themselves. So what you find here is that people may have difficulties with activities of daily living. Maybe they're engaging in maladaptive coping strategies. Maybe there's chronic suicidality, suicide attempts, significant physical health conditions, or maybe they're engaging in avoidance, isolation, rumination to a significant extent. In terms of community participation, we are looking for maybe folks are not taking care of their home. Maybe transportation is limited. Maybe they're not able to engage, in driving in the community. Maybe they're not able to leave the house. Maybe they've discontinued going to work, or maybe they've dropped out of school. There may be a lot of functional impairments that folks are struggling with, but these are often the folks that are coming to higher levels of care in our clinics. So what are some of the differences? Well, written exposure therapy depends on the level of care. We also want to acknowledge that we have an integrative protocol that has select features of acceptance commitment therapy, including values work. We do behavioral activation. We recognize patterns of thought. We teach people about the CBT triangle. We have a selection of DBT skills, including interpersonal effectiveness, mindfulness, emotional identification, and distress tolerance skills. And as well, we incorporate some mindfulness and self-compassion into our protocol. And so overall, we're trying to either help people to restore their functioning, or maybe for some folks that have always had a very difficult life, maybe we are helping them habilitate to the idea of finding a new way forward with their life. Lastly, some research suggests for including written exposure therapy in a higher level of care for PTSD and SUD residential is both effective and helpful in terms of a part of a comprehensive package, and that written exposure therapy does seem to function well in a group format. And overall, we really just want to emphasize that complex conditions really need comprehensive solutions. And so this is a part of how we deliver care comprehensively to help people move forward.
Great. Thank you, Dr. Michaels. That brings us to our last session section on recovery from trauma and promotion of resiliency factors. So we're going to walk you through a case. This is someone that we served in one of our clinics at Rogers. It's a 22-year-old college student who was recently unenrolled from college. We're going to walk through demographics in the Pamela Hayes addressing model. Their diagnoses were PTSD, major depressive disorder recurrent, and obsessive compulsive disorder. Under disability and physical health, they did struggle with insomnia and polycystic ovarian syndrome. In terms of religion and spirituality, they identified as spiritual but not religious, and specifically stated that they were scientific in their approach to spirituality. They were white, their sexual orientation was pansexual, and they had recently broken up with an alcoholic partner. They were raised middle class from an SES standpoint, but they were trying to become independent from their family as they began their college journey. And so finances were a big concern for this individual due to their lack of support from their family of origin. Their indigenous heritage was not known. Their national origin was United States, and they identified as non-binary using they, them pronouns. So for this individual, they spent about 1.5 months in our depression recovery program before coming over to our trauma recovery program. They had just experienced a significant episode of suicidality. So they really need to get stable and work on self-harm related considerations and suicidality prior to doing trauma work. When they came over into our trauma recovery program, they spent 8 weeks in our PHP program for 6 hours a day and 4 weeks in our IOP program for 3 hours a day. A lot of the things that needed to be addressed were from early childhood, physical and emotional abuse from one of the caregivers. And also, that was the past. And as we talk about balancing past and present, we also were balancing that out with that recent breakup with an alcoholic partner, where there were still ties to that partner. And there was still a lot of communication around the partner that had been emotionally manipulative and verbally abusive to our client. So through the initial 2 sessions of written exposure, this individual was tearful throughout, and they really could not maintain their composure. We were concerned whether they would be able to continue doing the written exposure because we were doing it in a small group format. However, in having discussions with them outside of that time, they requested to continue with written exposure. They felt that they could do it. We wanted to honor that request, though we were a little concerned if it would be disruptive to the group. But by the 3rd writing session, they were able to maintain their composure and do 30 minutes of uninterrupted writing. So in a case like this, we actually kept repeating session 1 until they were able to do it, and then we moved on to the instructions for session 2. So really, they had 3 session 1s in this case, and that's just how sometimes you have to adapt treatment when you're working with complex trauma. So what's fantastic is throughout the course of treatment, what we noticed is they improved their ADLs and sleep. They had very poor medication adherence at the beginning. They were able to improve that, which also helped to improve the sleep as well. We were able to walk with that individual as they ended the codependent relationship. Part of ending that relationship was actually going to Al-Anon meetings outside of our treatment so that they could better understand how they had gotten to become a part of that addictive cycle. They also had been isolated by their partner. So we encouraged them through behavioral activation to diversify their social interactions. And they actually ended up planning to re-enroll in college with a friend as their roommate for the upcoming semester. And they did end up re-enrolling in college and going back. And then one of the last things that they really attributed this improvement to the written exposure was the ability to confront one of their caregivers who had been physically and verbally abusive to them and emotionally abusive in childhood, and confront them about this very specific incident. And they attributed doing the written exposure therapy to being able to confront their caregiver around that. And they did decide to increase their limits and boundaries with their family. They had actually been caretaking the non-abusive parent as well. And they were able to set better boundaries around that level of caretaking, as well as communication with the abusive parent. So overall, if you look at measurement-based care, their PTSD symptoms went from severe to subclinical. Their depression symptoms went from moderate to mild. Their quality of life increased from significantly low to the normal range. And I also want to point out that those QID scores are after they had completed our depression recovery program. They still had moderate depressive symptoms, but those had started at very severe. And then on our behavioral activation scale, they went from very minimal activation, high avoidance, to high activation and little avoidance. Right, and so Dr. Michaels, back to
Hey,
you.
Dr. Butzen. It is. We have 3 slides left, and I promise we'll be done by 1:20. But I just want to highlight that these complex conditions where people have a lot of functional impairments require a lot of comprehensive solutions. One of the things that Rogers has focused on quite a bit is behavioral activation and wellness strategies from very much a new patterns of behavior. So in the work that we do, we take a very action-oriented approach. We are working to build healthy coping strategies, adaptations to life. Specifically in behavioral activation, we are targeting 3 main things. I often talk about them as sucking the air out of the room. It's avoidance, isolation, and rumination. And so we are targeting those 3 behaviors, and we are trying to use some opposite action on them to build up new patterns of behavior that are grounded in that are client-centered goals. And so more specifically, we are thinking about their activities of daily life, their routine activities, trying to build in some enjoyable or pleasurable activities. Sometimes folks are engaging in too many video games and they might spend 6-7 hours playing video games. But we want to have more of a life balance that also includes values and meaningful activities, as talked about in acceptance equipment therapy. So we're really focusing on building some new goals. And these behavioral patterns are really important because what we're trying to do is to focus on the value behavior congruence through a variety of life roles. And so what we're trying to help them understand is that if you have a diverse, well-balanced life, not only can we remove some of the things that are displeasurable related to PTSD or depression or other conditions, but we can build in some wellness strategies and hopefully help you access some moments of joy and connection and fun and curiosity. And I even feel myself smiling because I feel like that's why we do this work, is to help people live a full life. On the next slide, I'll briefly just talk about one of the components of looking at behavioral activation that we often use. And we are looking for, and this comes back to the case conceptualization model we talked about earlier, just to bring that back as a callback here. But we're often looking at stressful life events that are happening, what people's responses are to those things internally, and we are acknowledging their avoidance patterns. But we also realize that avoidance patterns means that there are also choices, which means we can engage in what we refer to as active coping. And so we are going to allow people to have a different choice and encourage them to try out some new things, experience what a different response might be, rather than calling out sick to school or work. What if, what might you do instead? And so we want to help them understand there are different ways of approaching this. But ultimately, the way that things are functioning right now makes sense. But let's try and intervene and try something different. As we turn to our very last slide, one of the things that I want to just talk about is the wellness wheel. And if folks are familiar with SAMHSA's wellness wheel, it is certainly different than the SAMHSA recovery wheel. But these are ways of trying to focus our attention to building wellness in different areas of one's life. And so in the work that we do, we are taking a comprehensive look at a lot of the things that people are engaging in for their life and ways that they can do things differently. We may have to not be able to cover all of these, but the idea would be that they would be able to take care of their sleep, their nutrition, taking care of like the physical infrastructure and their body itself, really understanding the emotional realm, how to not only identify and be aware, but what to do with that emotionality so that it can come, peak, and pass, but also that we can connect with people and build healthy relationships. In terms of intellectually, we want to be able to help them understand that having meaning and challenge and the ability to learn and engage in things and learn new things is going to help them have a growth-oriented mindset. And we can expand their identity beyond just being a person who is traumatized. Some folks end up looking at themselves as being broken and damaged, sort of unrepairable. We really want to embrace more of a notion of resilience and help them find the strength within to build community and connection, find that self-compassion, and find a new way forward so that they can have a full life that is driven around their values. And this is really about helping them find meaning and purpose and really living a full life. And with that, we can turn to questions.
Thank you so much, Dr. Michaels and Dr. Butzen. Lots of great questions coming through. If you do have questions, please make sure to put them in the Q&A in the Zoom taskbar. We'll try to get to as many as we can, but if we don't get to your question today, please feel free to send an email message afterwards to webinars@rogersbh.org, and we will follow up with you. So I am combining some similar questions here. What specific clinical indications would lead you to choose written exposure over PE or another evidence-based PTSD treatment?
Well, that's a broad question. I think there's a lot of different things that may result in that decision, right? Some of it is tolerability, right? If you know that you have an individual that you're serving that's not able, that has been struggling with engagement, you may want to choose a shorter treatment. That's more of a practical indication, not a clinical indication. The reality is that some of it may be due to their ability to share the story. So again, I think when you're working with evidence-based treatments that are all effective, that have all been found to be effective, a lot of it boils down to the individual, right? Those individual factors and some preference. I think, like, if you're and your training, right? Are you trained to administer these? Do you have someone you can consult with on these treatments? Because you definitely, I mean, in our setting, we've used prolonged exposure therapy and we've used written exposure therapy now, and we're able to consult with one another. We have experts within the system that we're able to talk to. So I think part of that's going to come down to training. Part of that's going to come down to that individual that's sitting in front of you and what they want to do. If you go on the VA website, there's actually a great descriptor of the different evidence-based treatments for PTSD, and written exposure therapy is on there as one of them. And so there's good videos. So sometimes we'll use those as just introductions to our clients. Like, here's some different options for treatment. Which one do you think would be most accessible for you, right? So that's that shared collaborative decision making. Yeah. So I try not to make that decision for the client, but with the client.
Absolutely. Thank you so much. A couple of questions about data and outcomes. One of which was, do we have post-treatment outcomes 6 to 12 months out? Also, are you seeing any differentiators between male and female or gender outcomes?
That's a great question. It is unfortunate that we do not have outcomes data beyond the post-test data that we have. Certainly the long range sustainability of these treatments would be a really important question for us to be able to address, and we would love to be able to do that. But that's beyond the scope right now. I do believe we had worked with our data analytics team and looked at the differences between male and female treatment outcomes. When we looked at that data, it was not significantly different in terms of PCL start or change scores. Certainly in the interest of time, we would have loved to have even more data, but as you can see, we've put quite a bit of information into this webinar, but maybe that's something we can talk about in a future webinar, is diving even deeper.
Absolutely. More to come. Absolutely. And then with the outcomes piece, with the literature that as it stands today, is it evolved to the point that we're able to identify any moderators of response, whether somebody may respond better to PE versus written exposure?
Dr. Butzen, you may have a thought on that, but when the American Psychological Association guidelines that were referenced earlier from 2025, there are some bigger questions about, what some of the mechanics are of things like, EMDR. There are still questions they have about written exposure therapy that we hopefully we have been transparent about, but they're looking for more information about what might be some of those things that allow people to be successful. I think those are some continued research directions that would need to be accomplished. Certainly a big plug for folks if they want to do research on this. This would be a great area to continue on, to sort of help the effort.
Yes, and we reviewed as much as we could, as many research studies as we could in preparation for this, but I don't remember coming across that study. If one exists, fantastic, send it to us in the chat, because that's probably a question. I mean, there's a lot of research going on right now around effective treatments for PTSD, so I wouldn't be surprised if there is research on that, but I don't know it.
Okay. Several questions about just like the treatment structure and what does that look like? One of which was, if a patient becomes extremely distressed during the uninterrupted writing session, maybe they can't write for more than 5 minutes, how should you balance encouraging an emotional engagement versus using of grounding techniques? How do you engage that patient? Maybe if they're avoiding specific elements of the event, verbiage, emotions, those pieces.
Yeah, that's a great question. We deal with that a lot in Atlanta when we're working with individuals. So, I mean, the big piece is it's kind of a both and, right? You're dealing with the dialectic there. If you don't want them to feel like this is a dangerous assignment, right? You don't want them to feel like this is too much for me to do. So you do want to encourage them to do it, but also, we're teaching our clients, especially in our longer programs, lots of skills to manage their distress. So if they need to take a break, if they can't continue writing, we would prefer them to take a break and then come back and continue writing. And we may end up repeating that session again, but the goal would be to show them that this isn't dangerous and you can do it, and we believe that you can do it. That we even had concerns about the client I presented that was very emotionally dysregulated for the first 2 sessions. But the reality is there's very few people that, if you look at the research protocol for this, that aren't able to make it through the protocol. So I think just encouraging, I mean, obviously there's individual differences, and some individuals may become very distressed. But I would just say, do you need a break? Can we practice our grounding skills that we developed, and then can we return to it and finish it, just to show them that they're able to do it? So just to decrease that avoidance as much as possible.
Dr. Butzen, I'd like to add a couple things. In the written exposure therapy manual that we referenced earlier, there is some discussion of a specific case with somebody who becomes dysregulated while writing. So that is something that they're acknowledging, and their approach is consistent with what Dr. Butzen is saying. But ultimately, it's also congruent with the case conceptualization that we described earlier, such that we want people to understand that their emotions and their responses are not dangerous. And so we want to think about encouraging them to, come back to this writing so that they can help teach their body, teach and re-regulate their physiology. We want them to learn that these things are not dangerous. And so we want some of that belief modification to occur. So that would be our goal from the treatment side of the house. And of course, we want to balance that like in terms of therapeutic alliance and being like being a down-to-earth human being with the person that's sitting in front of us, because, we don't know what they've been through, but we know some ways to help them move forward, but we want to be respectful of their limits and boundaries as we're trying to accomplish that. So
yeah, it should always be their choice. We can provide the rationale again, because there's often a lot of confusion at the beginning about the rationale, understanding why exposure therapy works. Like, why would I go and remember this horrible thing that happened to me? So, there's in the rationale for exposure therapy, there's a lot of discussion about being able to approach those events and have control over them again and take the power back from those events. But sorry, I cut you off there a little bit.
Yeah. One very quick last question. Are the clients taking the writings with them in between sessions, or are the writings remaining with the clinician?
Well, that's a very practical question. In our program, and I do believe this is the protocol as well, we maintain the writings. We don't want them to look at that in between sessions, right? So at the end of treatment, I think that would be a discussion whether they would take those with them or not. But during treatment, we don't want them looking at that in between sessions. The exposure task is the 30 minutes and then it's over. And then you do session 2. So we maintain those until the end.
Thank you. And that is all the time that we have for questions. I know questions keep coming in, so please feel free to submit those to webinars@rogersbh.org, and we can follow up with you. Please note that a recording of this program will be available here in the next day or two on our resources page, as well as our YouTube. And before we conclude, I'd ask the presenters to go to the next slide to show a couple of practical resources that we have for the group today. And then that about wraps it up for us. Within the next 30 minutes, you'll receive a link to your personal dashboard at CE-Go, where you'll be able to access the PDF of the PowerPoints as well as the handouts, full list of references for you today. For those of you who did meet the required time commitments, you will be eligible for those CE credits. You will also utilize that link to complete the evaluation for today's presentation, and you can download your CE certificate at any time on that personal dashboard. If you are having any issues or have any questions, please use that on that follow-up email. Please contact support@ce-go.com for more of those logistical pieces. And thank you so much for joining us today. Our community liaisons look forward to connecting with you, learning more about your practice, how we can partner with you and your patients in the community, and also to discuss more treatment options available here at Rogers. And on behalf of everyone here at Rogers Behavioral Health, we look forward to seeing you next time and have a fantastic day. Thanks so much, everyone.